Okay, I think we'll just go ahead then. So it's great to have you all here. I'm delighted that we've got such a number and wide range of people here this morning. I hope you're all well. My name's Lorna Rennick. I'm the Service Manager for the Health Equity and Inclusion Service in Public Health Scotland. And we cover a range. I always have a pause when I think about the range of issues that and portfolios that we have in the service, because it's quite wide ranging, but there are some that are very related to the area today, and you may be well have been in touch with the team across the different portfolios. So we've got migrant health, gypsy travellers. Obviously, Ailey McLeod is here. She leads on race and health, and also Claire Thirlwall is the organisational lead for the team. We've got homelessness, gender-based violence, violence prevention, women's health, and also, last but not least, we've got human rights and rights to health. So it's quite a varied portfolio. You can get in touch with any of the team through myself, Claire or Ailey. So just to flag that just now. Um, and also just to give a bit of background before I introduce our main speakers today. So as part of our work on race and health inequalities, we commissioned a couple of reports last year on structural racism in Scotland, and also just health and race inequalities. Edinburgh University helped us with those, and as a result, we're very pleased to have been able to host a couple of sessions with the team. We did one last week. It was an internal session in Public Health Scotland, and we're delighted to be able to do this session with our external partners and stakeholders, really just to share the learning and where we've got to. Those reports will be published. I think we're aiming for November, but we thought it'd be really helpful just to have the sessions, and hopefully they'll be helpful. They may be areas that are you're very well trodden for some of you, and for some others it may be areas that you're just new to and getting your head round. But hopefully it gives everyone some food for thought and something useful to take away. I guess just to say as well, the team have been visiting some of the boards just in advance of the ask from Scottish Government for all the health boards to have an anti-racism plan. So you may have been part of that engagement, and we've been working with the Scottish Government around the guidance for that, and also will have helped with forming some of the support programme around that. I think, I'm not sure, I'm not seeing them on my screen, but there'll be colleagues from NES here as well today, so I'm sure they'll be able to pitch in if we have any questions around workforce support. But so that's all that remains for me from me today. All that remains is for me to introduce people. So from Public Health Scotland, we've got Ailey McLeod. Ailey's going to lead you through the session this morning. We have Gwinnetta Curry, who is a reader at the Usher Institute in Edinburgh University, and also Emily McSwiggan, who is a teaching fellow at Edinburgh University, and they are going to guide us very, very capably and with lots of knowledge and expertise through the session. So I really hope you all enjoy it, and it builds on your current and knowledge, and challenges some of our thinking, because it certainly does every time I tap into one of these sessions. So over to you, Ailey. Thanks very much.
Thank you, Lorna, for that. That's great. So yeah, I just wanted to run through a couple of things before I hand over to Gwinnetta. We're going to use, so we've got a chat bar, which some of you have started using, and we've also got a Q&A box, which you'll see on the right-hand side of the chat at the top of the screen. You can use that to post anonymous questions. We will also have lots of space within the session to ask questions, and you can put your hand up like normal and ask questions. But if you want to ask them anonymously, you can use this chat the Q&A chat for that. And then you can also, once we start to have some questions, people can also vote on the questions, so that will bump up the most popular questions. So yeah, for many people will have similar questions, and then we can see which ones are the most pertinent to answer. So yeah, please feel free to ask anything. There are no silly questions or things that you think you already should know, like none of that applies. So please just like feel free, and you know, definitely people within the audience will be happy that questions like that have been asked. So, but yeah, absolutely feel free. So just to start, lots of us will know that some of this work, as Lorna was saying, like our work in PHS has been driven for multiple reasons to do this work, but all the health boards across Scotland have also been asked to develop their own anti-racist plan as part of the Scottish Government Cabinet Objective released in September last year. And many of you will know that that's supposed to be like a three-pronged approach, which focuses on changes within leadership, within workforce, and within equity-focused service delivery. So for the purpose of this work today, we're mainly focusing on equity-focused service delivery. Partly that's because of the work that Gwinnett done is obviously relevant to, you know, structural racism work is relevant to your workforce, of course, but yeah, much of the evidence would relate to the services that are being delivered, and my bit at the end is sort of about, yeah, how do you do that for service delivery? How do you make them services anti-racist? So we also know that some brilliant work is going on throughout the boards on all the areas, and some of it I'm going to mention within this presentation, but it's definitely not to say, like, if I don't mention your service, yeah, please know that lots of the work is really well known and it's really established. And yeah, I did some engagement work with many boards this year, and I thought that a lot of the work was really brilliant, and very, like, it was, yeah, brilliant to see all the work being done. So just to touch on like language before we start, we know that language is often a barrier to discussing racism and to discussing the people who are experiencing racism. When Gwinnett and Emily speak, they will talk about the language that they use and that is within the evidence base. So that'll be all different sorts of language. And Gwinnett, as a Black woman, can obviously use whatever language she wants to use. But at PHS, we've started to use words which describe the impact for people of being racialised and experiencing racism. So racialisation is a concept which Gwinnett will explain in a minute. Everyone is racialised. People who are white are benefiting from that racialisation, and people who are people of colour are generally not benefiting from it because of the system of oppression of racism. So we would describe people of colour in that situation as being adversely racialised. So if you will see that terminology in publications that come out or in some of the ways I will speak, that is what we mean by that. We also describe people as people of colour, but obviously you don't need to assume anything. You can just ask people who you're working with, or communities or third sector, how they would like, what language they would like to use. That's always the best way, and people can describe themselves in any way they want to, of course. Just to make a note too on intersectionality, we've been asked prior to this session whether we will cover like how you would develop an approach for anti-racism which covers all elements of intersectionality. That term was coined by Kimberly Crenshaw as part of the racial equality movement, and it was specifically designed to try to look at the experience of discrimination faced by Black women, because to date the racial equality movement had often focused on Black men, and feminism at that point was only really focused on white women. We now use that term intersectionality to describe obviously that all the intersections with different identities. And we can't, develop one size fits all, because we're all different, and even if we have different overlapping identities, we can't shoehorn everyone into one experience. And that's why it's really important to talk to your communities and your populations of people, or talk to third sector organisations in the central belt where there's, you know, like lots of expertise and bigger numbers, so people are not so identifiable. But I suppose like an anti-racist approach, if you do it really well, that kind of way of working, it can work really well for all different people who would fall under the Equality Act. It just basically is like really thorough planning, doing engagement properly, looking at your data. So it's not like a completely wildly different approach from making your services like work for people who have different protected characteristics. And we need to focus on race and racism and racialization now, because largely it has really been ignored. You know, we saw the impact of in the COVID pandemic, but that kind of issue for people who are adversely racialized and who are migrants was known about for 20 years before the pandemic. It just, nothing was done to put in place protections for people. And in 2022, CRER released a report, and in it they quoted from a survey done at the time, which said that 22% of people in Scotland felt like there was sometimes a good reason to be prejudiced against certain groups of people based on their skin colour. So we can say all we want that Scotland is not a racist place, but we do know that that is like a fact. And we also know that there's a growing population of people, and the ONS predicts that in 20 to 30 years, our population of people of colour will rise to about, I think, 20 to 30%. So I want to just hand over to Gwinnetta now, who will talk us through her session on structural racism and racialization, and later on Emily will discuss the findings of the systematic review that we did, and there'll be some moments for participation, and as I say there'll be some good moments for questions, and please start to use that question and answer chat box if you would like to. But yes, can I hand over to Gwinnetta now? That'd be great.
Thank you, Ailey. Thank you, everyone, for coming out this morning. I know, the sun is shining in Scotland, so we all should actually be outside. But you're choosing to spend time with us. I appreciate that. And let me share my screen. Hopefully all goes well. We practiced this a couple minutes ago. All right. Everyone can hopefully see that?
Yeah, that's great, Gwinnetta.
Yeah. Perfect. All right.
Could you put it on the slides here when you're ready? Yeah.
Yes. Okay, so hopefully everyone can hear and see me. Today we're going to talk about structural racism and health inequalities. I'm going to minimize this. Here we go. So as of now, I will say I can't see you because I have it on full screen. So if you have something that's urgent, you want to say it before we get to the Q&A, kind of raise your hand, and maybe Ailey and others could tell me that you want to speak. So outline of the discussion today will be an overview of key definitions, how does systemic racism operate in society, the effect of systemic racism on healthcare and health outcomes, and the impact of policy, and what can systems and institutions do. And there's going to be a list of further readings. Oftentimes we have these sessions and people leave wanting more understanding, because in 30 minutes roughly we can kind of touch on things, but you don't always get everything. So there'll be a list of readings that you can engage with at the end of this. My slide does not want to advance. There we go. So this is Barbara Field's definition of racism versus race. I know in the UK we use ethnicity and race interchangeably. I'm from the States, if you can hear from my accent. So that was very different and an adjustment for me when people were using ethnicity and race interchangeably, because in the States there's a definite difference. So we know that race is a social construct, right? It's been the idea that people are placed along this ladder, right, based on their phenotypes. And Barbara Phil says that race denotes a state of mind, feeling, or being rather than a program or pattern of action. Where when you're talking about racism, you're talking about the assignment of people to inferior categories and the determination of their social, economic, civic, and human standing on that basis. So if we talk about the beginning of the race conversation, it was noted that Black people were seen as at the bottom. It was used as a justification for slavery. They had different denotions of what it meant to be in each category, and white was seen at the top, Black was at the bottom, all the other races were in the middle. All right, and so that's how society has been organized. And so when we talk about the social construction of race, that is the construction of it. So the majority has decided, when we talk about white majority nations like the US or the UK, has decided this is where people belong in society. Okay. And this is their value, right? And a lot of the times it determines how you're treated. And it also, there's barriers to what jobs and things you are afforded, right? And opportunities. So I think this is the lens that I'm using as we talk through today. So when we talk about racialization, it can be thought of as an extension of a racial meaning that we talked about in the previous slide, unclassified relationship and social practice. So Omni and Wenat wrote this. They had a whole lot of back and forth with Joe Fagan about this term racialization, but it's an imposed, identity. So living in the UK, I'm seen as a Black woman. If we talk about on the census, I have to check Black other because I'm a Black American. If I'm in the US, it's African American. And so, when we look at ethnicity in the UK, there's 18, I think now 19 different categories for ethnicity. Race are the bigger categories. So they kind of clump together everybody from Asia, everyone from the African continent, right? So they have the bigger categories. And the reason that is that when I walk through the world, or when a racialized body walks through the world in the UK or the US in particular, we're seen in a certain way. You don't know that I'm a Black American just by looking at me. Although there have been certain interactions where people say, okay, she's Black American versus Black African or Black Caribbean through said interactions. But if I'm not speaking and just walking, you wouldn't automatically know what my ethnicity is, the cultural practices or religion and things that go along with ethnicity. But when we talk about race, the broader category based on phenotype, I've been racialized as a Black person. Okay. And it's also important to note that racialization is imposed on individuals and groups regardless of how they feel about themselves, right? So if, there was a story in the US, Rachel Dolezal, right, where she said that she was a Black woman, but she was actually a white woman. But it was about how were people treating this person? So if I said I'm a white woman, that doesn't really make sense. The society would not treat me or interact with me as a white woman. They interacted with me based on my phenotype. You understand? So that's when we think about racialization, how people have been put into various categories, regardless of how they define themselves. So systemic racism, I was trained at Texas A&M by Joe Fagan, and he wrote this huge book on systemic racism, and he would define it as systemic racism as a racial exploitation and an institutionalized and subordination of people of color by whites of European descent. It encompasses the racial stereotyping, prejudice, and emotions of whites, as well as discriminatory practices and racialized institutions generated from continuing domination of people of color. So I think very openly, most people understand overt racism. So overt racism would be the use of the N-word, people, racial slurs or physical attacks based on race. People understand that. That's easily identifiable. But if you think about the everyday interactions across, within society and our structures, covert forms of racism are actually enacted. So when we talk about covert forms of racism, it's about denying access to quality healthcare, denying access to quality housing, and quality education. So these things can be explained away a lot of different ways, right? So, oh, well, you didn't get the job just because you were, missing these different qualifications, right? But you'll see the exact same resume that comes across the table from a white person that would get the job. And so then you understand, like, okay, this was a racist act. If you look at the various communities, across Edinburgh, even Glasgow, where people are regulated to. So why are they, less families of colors in certain areas versus not? How does this happen? Right. And it's, some of it is limiting, or the people are experiencing discrimination when they're trying to get housing loans. And some of those things you wouldn't know, right? It's called covert because it's covered, right? It's this kind of hidden practices that occur. And it's not blatant. You don't know that. You just know you put in, you have your lawyer, you put in for your house, and you were denied, right? I often tell the story of my husband and I. We both, work at universities. We have what they consider stable income, but yet we still have problems when we first came here trying to rent a property. Not when they saw our names, but when we showed up, it was, oh well, we decided to rent to a family member, right? So it was an easy way for them to explain why they didn't want, people of color living in their homes or in their neighborhoods. So these are things that happen. Okay. So Joe Fagan came up with a theory called the white racial frame, saying the overarching white worldview that encompasses a broad and persistent set of stereotypes, prejudice, ideals, images, and interpretations. So if we think about how people engage in the world, how are certain bodies framed in the media, in our interactions, and oftentimes it's based on various prejudices. And on the next slide, we'll show this. So in the US, so when you see these two images, it's important to know on the left-hand side, Christopher Watts was seen as a family man. He's here with his wife and kids, but he killed his wife and kids. But this is the image that they used in the media. He was a murderer. He should have had the orange jumpsuit on. That should have been the image they used for him. And on the right-hand side, you have Trayvon Martin. Young Black boy walking home in the evening from a gas station with Skittles and an Arizona tea. He was murdered by George Zimmerman, who was seen as like the neighborhood watch guy who was there to protect the neighborhood. But Trayvon Martin was seen as someone that didn't belong in this white space. And George Zimmerman was someone that was supposed to be, policing the space. He had no actual authority, but he ended up murdering this young boy. And in the media, they posted images of him, what they thought looking like a thug, right? And they tried to tear up his image like he was this bad person. And he was a kid that had no weapon, was not doing anything wrong. And so when we talk about what does a criminal look like, Black men and boys in society are often criminalized. And you have Christopher Watts as a white man that still, after committing this terrible crime, this murder, he's still seen as, oh, he's a family man, right? These are the images that are being used. So when we talk about the migrant crisis, so the previous example was US based. Oftentimes when I'm talking about this, it's like, oh, that's the US, that's not here. We don't have this problem here. But you do have this problem here. And it's like coming is more prevalent in the media now when we look at things. So we talk about in 2022 when we had the Ukrainian refugees coming over, and it was like we welcome all refugees, right? And they were given certain privileges. They were like the golden ticket refugees, right? So you think about how they were treated versus how the migrants that are coming over from what they call the darker nations, right? They're seen as criminals. And people in this image in 2025 is from the BBC, says people are angry behind the wave of asylum hotels. So people see it as an attack on Britain. You're changing our country, and they feel like they're defending their nation. So the question is, why didn't they feel that their nation was being taken over when the Ukrainian refugees came over. But when you have, Black and brown refugees come over, this is a problem. There was actually a news segment on the BBC that, talked to some of the protesters, and they were like, oh, well, they have different cultural practices, talking about the Black refugees. They have different cultural practices, and I'm afraid they're going to rape our women and children. So these are stereotypes when it comes to Black and brown men, that they're just there to, rape women and take advantage of children. And these are the narratives that are put out there in the media. This is what people believe. This is what's being shown. And this is important when we talk about race, because what was the major difference between when the Ukrainian refugees came and then the refugees from the other nations, right? There was a marked difference in policies and access given to each group. So when we talk about medicine, I teach medical students the early years. And so it's important to think about, how does these biases that I just talked about, that we saw in the media and how we treat people, how does this overlap into how patients are treated? So when we think about the healthcare system, doctors are meant to do no harm, treat the patient in front of them, and that is their aim. But the study on racial bias amongst physicians noted that recent studies suggest that even when Blacks gain access to healthcare systems, they are less likely than whites to receive certain surgical or other therapies. Whether disparities in treatment decisions are caused by differences in income and education and social cultural factors, or failures by the medical profession, they're unjustifiable, right? And must be eliminated. So they're talking about how these patients are treated differently. You had 2 patients turn up at the A&E with the same injury, but they received different treatments. And that's what the study showed. So if you were Black and brown, they put you in a splint and sent you home and say, okay, go see your GP. If the patient was white, they will take on the surgery and fix the fracture. All right. So these are studies that were done, and it kind of shows evidence of these type of biases. Biases may be overt prejudice on the part of physicians, but more likely they're subconscious. So the subconscious bias occurs when patient membership in the target group automatically activates different cultural stereotypes. So sometimes when people of color come into medical settings, there's stereotypes written onto their body. They're pain seeking, or they're just, we had these conversations around maternal health. Oh, they're being dramatic, right? Or they can endure more pain. So these type of stereotypes are being written onto the patient's bodies when they come in, before they even open their mouth often. I really like this example of the Black man hailing a cab in New York, and the physician deciding on who will get what kidney. Most people see this as having nothing to do with each other. But in New York, there's a stereotype that, Black men are violent, they won't pay for the cab. So oftentimes it's hard to get a cab in New York City, for Black men in particular. Physicians deciding on who would get a kidney. So there were different stereotypes related to Black people being less educated and less likely to follow post-transplant protocols. So they will be knocked down on the list. There's different things you have to have in place to even be put on the list. And oftentimes, if you don't have someone there to help you with post-operative care, they won't do the transplant, right? Those things are very simple to point out. But these stereotypes of who will follow the protocol versus not, these are assumptions that's being made about Black people, is not necessarily evidence, right? So when we see this diagram and we think about what we just discussed around racism, how it comes over in medicine, and this diagram kind of lays out the root causes, which are institutional racism, class oppression, gender discrimination, and exploitation. And how does that lead to a power and wealth imbalance? So limiting access to labor markets and education system and housing. So some people would think these things have nothing to do with each other, but if you don't have the power to determine where you work or, have access to quality housing, that can have a huge impact on your health outcomes. And it's important when we talk about the social determinants of health, it can impact people across all, ethnic backgrounds. But as we look at the data, it is very often that we see that racialized minorities in the UK are experiencing a higher rate of these type of disadvantages. And so the social determinants of health in terms of lacking transportation, job security, and quality education can increase stress outcomes. So when you talk about unhealthy behaviors, like who's smoking, who's drinking, there's a lot of stigma attached to people that have what they call unhealthy behaviors. And a lot of the efforts that people have onto fixing these unhealthy behaviors are not dealing with the root causes. Like, how do you ensure that people have access to healthy foods? How do you reduce their stress so they can have healthy behaviors, right? So all these things link into how illnesses become more prevalent in certain populations versus others. This is just
Cold and
diagram.
damp housing, mold, energy efficiency.
I don't know why that happened. But so when we talk about damp housing and poor housing outcomes, we're showing that, you have damp housing, mold, fuel poverty. So, like, are you having issues with gas? So you have to put money on your gas meter to warm your house. So all of these things have a negative impact on your health outcomes, and those are the greatest risks for poor housing are older people, children, and those with existing health problems, and those who are unemployed. So when we think about who fits in these categories and who's overrepresented in these categories, the data is very clear that people with comorbidities are going to be vulnerable in these type of housing situations, and across the UK, racialized minorities are disproportionately affected by comorbidities. Let's see.
Again,
There we go. Housing discrimination. So Black, African, and Arab groups had the lowest rate of home ownership compared to 68% of their white British counterparts. So we think about the previous slides when we talk about wealth and power. People gain wealth by having houses and property. If you think about how much money, residual money you would have if you didn't have to pay for housing, it's massive. All right. So think about how that goes from one generation to another and what does that mean for your opportunities. These are just a couple quotes about living conditions. This quote says, BAME households had lower access to quality housing and are more likely to live in overcrowded houses and more likely to face homelessness. This was very important when it came to COVID-19, because in COVID-19, people were asked to, social distance. And if you couldn't social distance, you're more likely to contract the virus. But what did it mean for people who lived in overcrowded housing? Educational attainment. So white and Black and Caribbean pupils were 3 times as likely to be excluded from school versus their white British counterparts. So when we talk about, increasing educational attainment, it's directly linked to your opportunities to get a better job, as well as it is to live a healthier life. These, when you talk about job employment here, I'm running out of time, I think. Unemployment, the 3 groups with the highest likelihood of unemployment were adults who were disabled and identified as other ethnic groups: Arab, which 17%, Black and Black British, Black Welsh, Caribbean, and African. African was 11.1%. Or Asian British, or Asian Welsh, and Bangladeshi was 11.1%. And this is the data from Understanding Unemployment, What Role Does Ethnicity Play? And so when we talk about employment options and what does that mean for health, we have to think about, why are people out of work? What are the drivers? What are their experiences? a colleague of mine did a study, the report is by Prospect, where she had funding to look at employability among, migrant populations. And what she found was that, well, they are very much employable, but they still weren't finding jobs. It was to the point where some of them had to take PhD off of their resume to just to get an opportunity to be employed. And this was something interesting because the study was done in Scotland. And when they left Scotland, they felt like they went down to London and they got a job within 6 weeks. So what is it about Scotland that they're experiencing these type of discriminatory actions? This is a diagram of the Scottish labor market from 2011 to 2024. And it's a clear demonstration that it's still almost 10% difference between, labor market engagement in the white groups versus minority ethnic groups. I don't like that they put everybody together in this. I do like to have more disaggregation in data, but that's what was available. But it really shows from 2011 to 2024 that we still have a major problem. Police harassment. Black and Chinese ethnic groups in Scotland have particularly high levels of reporting racist insults and unfair racist treatment from police. Again, when we talk about this, oftentimes, it's dismissed as, oh, this is an American problem, this is an England problem, but this is Scottish data. This is the report on racism in Scotland. So it's important to know that this is something that happens here and not just across the borders. And so the next slide, the next short video I'm gonna show you is from this project called Co-Power that was done under the pandemic. And I can share this. Hopefully everything works correctly. Can everyone hear? Perfect.
Are you treating me like this in front of my kids for allegation?
There is not allegation. Allegation.
And you're hurting me.
I'm not trying to hurt you. I just want to get out of the car.
And you're taking my property.
You're saving your phone.
You're saving my phone for what? For what?
Stay in the car.
Chill. Chill. I'm asking you a question. You arresting me. You kidnapping me with no reference. This is kidnapping. This is the second time you guys kidnapping me. And I was like, what? Great. But they're like trying to make it look like they're trying to be professional. But you cannot be professional if you do that in front of my wife and kids. What was that for you?
So the kid, I was shocked. The kids were upset because they have, the little ones, they have never experienced it. I've never experienced the and especially arrest of my husband and accusing him of such a thing, which I would not even believe it for a second.
By the way, they didn't wear no mask, no even mask, and this is pandemic. And they're supposed to be, they're finding people like us. Nobody, I complain all that. They blame her for staying on the scene with the kids. And you think she's just gonna walk away, my kid's gonna walk away? That would destroy them because you just kidnapped me.
And when we see 5, 6 police officers on our dad, like holding him, grabbing him, it's like, oh my God, we are going to be one of them families that are like praying for our dad and like who are attending our dad's funeral because he's being killed by the police.
We haven't properly experienced this before. Like, it was the first time that we saw our dad getting arrested like that. And like, know that there was like so many police like officers on him. It was just like, we didn't want to see that. Like, we weren't meant to see that, in my opinion.
My skin become a criminal in this town. I become a target because of my skin. I can't see anything else. I don't sell drugs. I don't walk around with guns. I don't take drugs, even on my lowest points.
I know that is challenging for many to hear, but it's very challenging as well to experience. And I would like to say that, Ahmed has since passed away, and he was never charged with anything that he was accused of doing. the sheer stress that he experienced of being arrested over and over again had a major impact on his health. So when we talk about the impact of stress and health outcomes, it is real. This is not something that you could separate. It's not abstract. It's, oftentimes we talk about experiences of racism as being, oh, this happened so long ago, or it's this one moment in time. And, people, can often dismiss it. This diagram kind of shows how racial discrimination can lead to poor health outcomes. And I know I don't have a lot of time left, but I'm going to say, if you experience racism, as you can look to the left, it says racial discrimination. It's not only you experience it and you get over it and you move on and do great things, so you could do great things, but look at the impact it can have on your health. If you look at the strand that goes through the middle, the psychological stress leads to physiological stress, which increases various hormones in your body in terms of cortisol, C-reactive proteins, and that's perfectly fine if you are, fighting a bear. But if you are not fighting a bear, and these levels stay high, it has detrimental impacts on your organs and your overall health outcomes. And if you see the box in the bottom right corner, you talk about physical health outcomes, cardiovascular disease, decreased birth weights, increased hypertension, as well as physical injury. So that kind of pairs with the data that you see with racialized minorities in the UK. So we have to think about, yes, there are issues around healthy behaviors. What are the drivers behind it? But what are their experiences of stress that's also contributing to these comorbidities? So that's something to keep in mind. When we talk about weathering, some of you may have heard this term, some people haven't. Airline Geronimus came up with the term weathering, his hypothesis actually, which means that Black people experience early health deteriorations as a consequence of the accumulation of impact of repeated experience of social and economic adversity. So if we think about what we just saw with Ahmed, these things happening over and over again, and what does it produce? Right? And how does this affect your overall health? The allostatic load produces wear and tear on the body. So we talked about these hormones that are going throughout your body when you're experiencing stress. Your body never reaches a level of homeostasis. And what does that mean for pregnant women that are experiencing stress? Their babies are experiencing this stress as well. And so it has a detrimental impact on their health. These are just some statistics that show some of the health disparities. The Scottish Diabetes Survey showed that type 2 diabetes is more common among and earlier in South Asian populations compared to white ethnic groups. We talk about obesity among Black people in the UK being high, as well as cancer diagnosis being reduced for all groups except for Black and other ethnic populations. So these are important things to note in terms of the disparities that exist across the UK. And I'll just quickly talk about the history of gynecology. So in gynecology, James Marion Sims is seen as the father of gynecology. And, he has been held as some hero. But a lot of people do not acknowledge that he conducted his studies on the bodies of enslaved Black women without anesthesia. And this has fed into the different stereotypes of Black people being able to endure pain. In the US and the UK, Black women experience more pregnancy-related complications and mortality compared to their white counterpart. And this is regardless of socioeconomic status. So a lot of times when we talk about improving outcomes, it's about, let's improve education and access, but this still exists regardless of education. I did a study with Dr. Jiva John in the Lothians area where we interviewed minority women and they talked about their care during the pandemic and their experiences of racism and discrimination in their care. And I'll just read a couple of these. An example of institutional racism is that, and when they asked, they have refused to stitch it back again. And they just told them to keep taking painkillers because they were in huge pain. And my friend I have seen, she couldn't sit. So when we talk about they said, oh, keep taking painkillers, but you understand this is, paracetamol. This is like Tylenol. This is not, any heavy pain medicine that's really gonna, really have an effect in taking that pain away. So these women are experiencing pain and not being cared for. We did another study with, NHS Lothian and Quiza, where we did focus groups with women of African descent across the Lothians, and they had very much similar outcomes in terms of feeling dismissed and not heard. So what can systems do? They can conduct internal assessments and look at the barriers against providing equitable care. We understand that there's a lot of stress on the system in terms of longer wait times, a lot of demands, but why does it fall on certain groups to experience this more than others? Racial equity impact assessments. So examining how the different ethnic groups are likely to be affected by proposed actions. Oftentimes policies, things are enacted without the consideration of all groups. As health boards and governing bodies, you're there to serve everyone in society. So it's important to make sure that is the case. And also create and support culture of safety, centralized reporting. Oftentimes people have issues, but they don't report because they don't feel safe reporting those issues. This is just a slide that talk about how do you speak up, set limitations, practice and prepare, apologize. If you say something wrong, don't be afraid to apologize. Oftentimes people don't want to apologize for various reasons, but it's important to do that. Uncover and learn. It's important to constantly learn. I think we're learning something new every day. I think a lot of people will have times where they don't know something, and it's important to ask questions, speak up. There's no stupid question really. So be cautious, but definitely ask the questions you have. Continue to create data. Data has been a major issue in terms of trying to find out what is happening because if ethnicity data is very poor. Implement unconscious bias and communication training. I think that unconscious bias training sometimes become a tick box exercise. So we want to move past that to make sure there's some accountability. So once you understand you have a bias, how do you make sure that those biases don't impact your quality of care? And in conclusion, anti-Black racism is a global problem, and the COVID pandemic really highlighted that. The COVID pandemic, as well as the migrant crisis that we have going on, is really highlighting the different ongoing disparities across the UK. And I kind of like this quote, this final note, that health is not there solely in the hands of individuals, but the environment and the conditions in which people live and work, which shape health behaviors. And these are some further readings. And I think Ailey's gonna send out the slides. So thank you. You can ask some questions.
Yeah, if anyone has any questions just now, we can open the floor just now.
See, the Q&A has something. Let's see.
Yeah.
Let's see.
So there's two questions, Gwinnetta. One on can you read them, or do you want me to read them out?
Not showing up on my screen, so if you could read them out.
Okay. So the first one is well, the first one that was asked. Okay, I'll just read them in order. The first one that was asked is, I really struggle with how refugees are being treated at the moment. How do you make sense of so many high-profile politicians, both of people of colour and white, who seem to think it's okay to treat these people in such disrespectful ways and make it clear they're not wanted?
So how do I make sense of the racism that that's being portrayed? I think that some politicians are kind of riding the wave. They are looking at how people are protesting and they want to feel that they're protecting their country, right? And so whether they believe it or not, they're following along that because they want to be seen as a part of, protecting Great Britain. Whether you are white or not, I think that we probably know exactly the politician of color that we are speaking about. But they can also be a victim to their own demise in terms of falling into different white supremacist logic of how you see racialized bodies in the UK. Oftentimes migrants have been criminalized, right? And I think there needs to be understanding that oftentimes migrants are coming over because of the conditions that they are, have in their home countries, which are often driven by the actions of the UK as well. And so I think that is important to note. Oftentimes we try to divorce the two, but it's like, if you look historically, the UK has invaded nations across the world, right? And so honestly, this is my take. Honestly, I think that yes, we should have an open door policy. They have taken and pillaged from all the countries across the globe, so they kind of owe these groups, refugee status. They should allow them to come in, and I think it's despicable that you'll allow, no limit to the number of refugees that were coming in from the Ukraine versus the refugees that are coming in from, the other nations. And I think that, that shows a clear difference in issue in terms of white supremacist logic on, okay, we see these people, they look like me. This is part of the issue. They're like, okay, the Ukrainians, they look like me. And then they totally ignore the Black Ukrainians. Black Ukrainians, there was article after article showing how they were separated from their families, and they were not given the same privileges as the white Ukrainian refugees that came in, because they were immediately put into a separate category just based on their skin color.
Thank you, Gwinnetta. So there's another question about language, but just before that, just to note that lots of people were saying thank you very much in the chat for your presentation. It's really powerful. So yeah, just to acknowledge that. So another question is, why do we still use and normalize the use of othering terms such as people of color and colored, which originated in and also is primarily used in the US, and that were used in places such as South Africa? Is there a way to dismiss these terminologies in favor of equal terminologies? And then someone has also asked whether global majority is a term that's positive, or is it a good option?
I don't mind the term global majority, because I think it's true that the majority of the world is not white. But why do we still use terms like people of color and, group of people together? I think that when you were talking about one group, so if you were talking about Black African people in Scotland, I think you named the group you're talking about. Right. And I think that when you're talking about, Bangladeshi people, it's important to note that you're talking about Bangladeshi people. But if you are putting all groups together, as you saw in some of the graphs from the data, they say minority ethnic because within the UK, they are racialized minorities. So I think that's the term that's being used. I don't think that's going to be a term that everyone's happy with. I think that's just important to know that if you're actually talking about, Black British people or Black African people, that you name the group you're talking about, oftentimes they'll say, racialized minorities, or they'll say people of color when they actually just mean, Black African or Black Caribbean. And so it's important to name it when it's possible. But there are instances where you are talking about collectively, adversely racialized populations. And I think I'll just add this one bit. Racialization, the process of racialization itself is a violent act. You are noting where people are on this racial ladder, right? But it's also understanding how people are treated in society. So in society, like I said earlier, I'm treated as a Black woman. And it's no waking up and feeling differently and say I'm something else, because society has put me in this position, whether I like it or not. This is how they engage with me. And as a sociologist, that's how we, measure things.
That's great. Thank you, Gwinnetta. Okay, I'm just looking at some of the other questions that are in the box just now. Okay. So Oliver has asked a question about like the history of the NHS having benefited from the colonial legacy and the continuing power dynamic we see within Western medicine. Is there any hope for initiatives like realistic medicine to address systemic racial inequalities? That's what Oliver has asked.
Is there any hope? I will honestly say that if we talk about who has power to change the system, oftentimes racialized minorities don't have that power within that system. I will say that the history of the NHS is pretty interesting. There's a whole documentary about how Black women saved the NHS. I don't know if you haven't watched it, you should definitely check it out. It's completely free. But, the NHS was built off the back of Black and brown women that that came over from the Caribbean and parts of Africa because they didn't have the manpower to sustain the NHS. I think that should be acknowledged. I think those contributions should be acknowledged. And also under the pandemic, I was shocked by the front page of the news where they had all the deaths from the NHS of, doctors and nurses and whatnot. And it was overwhelmingly people from racialized minority groups. So it really demonstrated like who was on the front lines. And the country seems to have a ebb and flow and when they value racialized minorities contributions in society versus not. So under the pandemic, it was like, oh my gosh, they're doing these things. But then they were also on the other side, oh, they're the ones, spreading the virus, right? It became they're the problem, not us. But yet we are depending on them to run the society. So if you think about who was keeping the grocery stores running, who was working on the front lines, who was running the transportation, it was a racialized minority. So there is value in that, right? But they're not valued in society as a whole, because if you look at how people are engaging with, policy now, oftentimes it's not something that benefits, all groups.
Thank you, Gwinnetta. That's great. I would quite like us to move into Emily's presentation now, if that's okay. So Emily's going to take us through some of the findings from the systematic review, and I will also cover some stuff about how we do anti-racist planning for healthcare services after that, and then we'll have an opportunity for some more questions after that. So Emily, I'll hand over to you now.
Is that right? Gwinnetta, are you introducing report 1 before I move on to the review?
That's fine. Yeah, I'll just be quick about it. Hopefully everyone can see this. So as Ailey said earlier, we were commissioned to do 2 reports, where the first report kind of covered terms of race, racism, racialization, and how does it lead to poor health outcomes. Report 2 was a systematic review of the evidence in Scotland. So this is going to be the outline of this. So the overview of the key drivers and mechanisms by which racism, discrimination lead to poor health outcomes, including mental health outcomes. So we were asked to cover a lot in this particular report, but the first report kind of covered key definitions and just evidence on the links between experiencing racism and poor health outcomes, looking at intergenerational trauma as well as epigenetics and weathering and race correction. Often in medicine, they've been historically used these race corrections, and there were 12 different race corrections that were being used. Some of them have been removed, and so we talked through that during the report. And in my presentation, I kind of went through racism, racialization, and health inequalities. And so I'm just going to lean over to Emily so she can kind of talk through, and she's going to also tell us about all of the other people that are involved in the report. I'd speak really quickly, so Emily's really good at this.
Fab. Thank you very much, Gwinnetta. I can't take control because it's disabled by the team settings, so I'll just ask you if you don't mind clicking me through. As Gwinnetta said, we did a systematic review. We were looking for what the published academic evidence base on health inequalities, particularly racialized health inequalities in Scotland, stands at the moment. As Gwinnetta said, there were a team of us involved in delivering the review. Gwinnetta and her husband, Professor Tommy Curry, who also needs no introduction, myself and 2 other PhD colleagues, Emily Adams, whose work is mostly related to homelessness and aging, and Kayla Ostrishko, who is working on the aging experiences of Black people in Britain. So again, both of those with relevant experience that might be useful for you to link into it at various points in your own work. Just to explain a bit about systematic reviews, they have a very structured methodology. The aim is to be able to answer a very precise question very clearly, but that means that they're quite focused and quite narrow in terms of what evidence can be found by a review question, can be deemed in scope, and what evidence is not in scope. And that means that some of the nuance, the broader context, the information that might exist in unpublished or non-academic literature is not going to be picked up by a review of this nature. So a review will give you a fairly robust academic picture of the things that we know best through scientific research, but you might think, okay, well, I know there's stuff out there about X or Y. Why hadn't the review picked it up? And the answer is likely to be because it either doesn't directly correspond to the question that we were trying to address through the review, or because it has been produced in perhaps a non-academic context with some of the without some of the sort of scientific rigor that you would expect from more academic processes. So this is giving you sort of the core of what's available in terms of academic evidence on racialized health inequalities, specifically in Scotland. And we concentrated, as you can see from the slide, on these sort of 6 headline areas where we know that there are particular concerns about differences in health outcomes, but we also picked up any evidence that we could find in general terms about these inequalities. We looked for any evidence we could find about the impact of race, racialization, and racism on life experience and health outcomes, and anything that we could find about systemic issues within policy and practice, again, specifically here in Scotland. Gwyneth, if you don't mind moving on the slide. These are the methods. We don't need to go into them in any more detail, I think, at this point, but on the next slide, you'll start to see some of the results. So the results for each of the sort of 6 headline conditions are fairly similar, and they point towards a consistent pattern of health inequalities, but they are incomplete in the sense that they won't tell you everything about every health outcome from the perspective of everyone who's experienced adverse racialization in Scotland. So, and that's because that's partly because research hasn't always been done that looks at those things. It's often because numbers are small, but it also, and you'll see this in some of the next slides, has to do with the way that people are codified or not codified in terms of putting people into boxes on systems relating to race or ethnicity, and whether people get to self-identify or whether those identities are imposed on them. So the processes of creating and making sense of the data also affect what we can learn about differences in experience. So some evidence of inequalities in CVD, but plenty of scope to research that further. And then on the next slide, similarly in cancer, some of the interesting things that you might pick out here is not only that there are inequalities in outcomes, but also inequalities in terms of what's protective and who we are thinking about when we are planning health promotion and protection interventions. So, a need for culturally specific screening interventions, interventions that recognize particular concerns or experiences or interactions with the health system as being particularly useful, but not necessarily always planned or offered. And so thinking more about what do people need when we're planning health promotion interventions, as well as responding to health outcomes. And on the next slide, I suppose mortality and life expectancy is sort of the headline in terms of this could be for any reason, but again, starting to notice differences in life expectancy, but not necessarily in a very finely grained detail. So you can see on the left-hand side, one study used just a binary between outcomes amongst white and non-white groups, which is not very helpful in terms of sort of any kind of nuance or detail about people's experiences. And on the next slide, again, the picture is consistent, but incomplete. A lot of the studies that have been done focus on South Asian populations, possibly reflected previous demographics in Scotland and not so much some of the more recent population change as well. Some of the studies in this section, as I recall, went back decades. So, there's also a need for more up-to-date research. But one of the things that starts to appear here, we've talked a lot about the experiences of migrants, especially refugees and asylum seekers, and recognizing asylum and other migration-related processes as a determinant of health in its own right, and often a particularly detrimental one. So on the next slide, again, in terms of maternal and neonatal health outcomes, we see different patterns of outcomes. Gwinnetta talked us through the history of gynecology, and it's stark, I think, to see that translated into poorer present-day health outcomes and poorer present-day treatment. And that's something to really bear in mind, how intertwined our history and our present still are, and how important it is to consider that. So on the next slide, again, differences in mental health outcomes appearing across the board. Here you can see some of the problems that I highlighted about the way that people are categorized, and the differences between how someone else might classify you and how you might identify yourself. Again, the importance of recognizing differences in what health services and protective services are trusted, are welcomed, are useful. So you can see, a preference for third sector and peer-led support, which is important to include in planning for health services and interventions. Making sure that the services that we provide are responsive to the diverse and different needs of our population. So on the next slide, we found some evidence. Again, I would say that the evidence base itself is pretty limited, but that doesn't mean that this is not happening. It means it's an under-researched area, but definitely found some evidence of racism and racialization having an impact on health outcomes. People experiencing barriers in accessing services, and experiencing direct discrimination and prejudice, which affect their ability to live a healthy life. So I think the next slide is, yes, the final one. So coming to the recommendations from the report. Obviously, as academics, we are going to say more research is needed, but I think that you collectively would see that is the case. There is so much more to uncover in terms of the diversity of people's experiences, and the research to date that is specific to Scotland has only been able to look at a fraction of this. There are particular gaps related to the experience of Black populations in Scotland, and so that is a particular need to address, given what we know from other contexts about stark differences in outcomes. There's a need to improve the quality and the clarity of the data that we collect, how it's made available and how it's used. And of course, a need to do that in trust-building ways, so ways that ensure that people aren't further harmed or discriminated against as a result of how we deploy data. And there should be a greater focus on building awareness and understanding of the role that racism as a specific determinant of poor health plays in creating greater health risks and poorer health outcomes. So that in a nutshell is the review, but together with Gwinnetta, I'm very happy to take any questions.
So there are a couple of questions in the chat, but I was thinking, unless people want to ask any just now, that we could maybe move into the anti-racist work, just so that we cover that off, and then people can ask questions about that as well, if that's okay. Some of the questions are more broad. What I was going to say before I started that input was that out of the engagement work which I did with boards across Scotland this year, a lot of boards said that they would like to connect with other boards. So as a result of that, PHS are developing a peer support kind of network for boards, for all boards, and it will be like, initially it'll be 4 to 5 sessions which we lead and which we can like program, so we'll have like learning input in all of those sessions. When I did the engagement themes like data, not just data gathering, but like data analysis and what to what to analyse on, and things like engagement of both your staff and population group. Those kind of themes were coming up, but I know that that was 6 months ago or more that I spoke to people, so it'd be interesting to know now what kind of things you would need help, what you would like help with, or you would like to learn from other boards on. So yeah, you can email me directly, or you can post things in the chat about things that feel like big gaps right now. And I'll be in touch in the next few weeks with some dates and some the kind of topics that we'll be maybe covering in those sessions. And they'll run from probably November this year until probably June next year. And then after that, boards can take on the leadership of that network between you, so you can continue. It's not just for learning sessions, it's for like networking, because I know there's brilliant practice, and we just want to make sure there's good sharing and connection across Scotland on the work that's being done. So I'm just going to open up my own presentation here. Okay, so the first thing to say is, I'll get rid of this. I also now can't see people, but if maybe other people, Gwynetta and Avril, can help with the if the people have their hands up. So just to say, first of all, yesterday I spoke to Andrea Lenson from Scottish Government. She wanted to put out to say, she wanted to say, like, anyone from any boards, if you have issues or questions or need support with your anti-racist planning, please be in touch with them directly. You can have a conversation with them, you can ask questions. Some boards have been in touch with them directly. Like, this is obviously beyond the formalised channels of reporting and stuff, but they are more than happy to have particular conversations with anyone about anything you're doing. So please do that and don't be shy. That's the email addresses there, and I'll put them in the chat. So I wanted to just cover some stuff on what is anti-racist planning for healthcare and why do we need it. So I've put in the title there for healthcare and public health. Obviously, for public health, it is a bit different how you would do it. But in the session that I ran for PHS a couple of weeks ago, then my topic for that was public health. So there'll be people in the audience today from public health, and I can send you the slides and the notes from that other session so that you can read it from a public health point of view. But yeah, predominantly today, this is just focused on healthcare. So anti-racism is basically using different types of data to understand the issues and health inequalities for people of colour. And we want to involve communities to develop properly person-centred care. That was kind of the findings when I did the engagement, really, that basically ultimately what we're talking about is properly person-centred care. And we all know that we're working to do that anyway, already, all the time. Like, you're constantly thinking about how you can adjust things to make them work for people that you work with within healthcare settings. But the main, the caveat to that and why we need anti-racist healthcare is because healthcare and public health isn't just objective, and the way we have developed, the way systems and healthcare has developed, has not just been done in a objective way. We think it's objective because we've always lived with it the way it's been developed, but that's just like a fallacy of neutrality. And actually, when we don't question it, this way services are run really do favour people who are white, and often who are cisgendered and heterosexual and non-disabled. And that's just because, our system, as Gwynetta was explaining, has been built up through this colonial legacy, this imperialist legacy, which puts white people at the heart of the top of the hierarchy. All of our kind of structural services in Scotland and throughout the UK, kind of are developed on that basis. But we need to be really awake to that now, basically, and not think that is the only way of doing things. And we need to do it in a proactive way and not just think that we'll bang on an EDI approach at the end of once things have been developed, because we know that that's just a way of developing. So when we do work that's anti-racist, we're not prioritizing racialized people over white people. We're just needing to like reset the balance, because historically it's always been white people who've been like favored within healthcare, not for like unconsciously, of course. And what I've done is link in the slides there, and I'll put in the chat the anti-racist principles that have been developed by the NHS England Race and Health Observatory. There's lots of good stuff there, like fact sheets, 7 principles and 7 fact sheets on things like race science and race bias, which make it really easy to understand these concepts. So how do you go about doing anti-racist work? It's what we need to do is have a standalone anti-racist plan, which many of you will have, and to embed that anti-racism within services. I know some people have got their equality outcomes, and they're embedding the anti-racist work that way. So long as it's explicit and you know what you're doing, and you're like looking at it properly and not just thinking we'll do an approach that works for all equality groups, then that's the kind of focus that we need. I've said it already, but please don't assume like a EQIA approach would be adequate. It wouldn't be. Anti-racism is about like underlying action and different things being developed to suit people, rather than it being checking at the end whether you think discrimination could occur within the way you've developed things, because you won't spot it, and you would need like properly people around the table in order to spot it, people of colour around the table, and you should be doing things like properly and developing different kind of interventions. So it's really important and good if you can start your own like internal anti-racist journey. So like, it can take quite a long time to understand like how the kind of system of white supremacy operates within our society. Don't take it personally. We're just all like, as white people, we're benefiting from it, but we're not aware of that until we start to think about it and to look at it. So like, don't take it personally, but do the work. And some of these authors that I've mentioned are a good place to start. The book Me and White Supremacy was published a while ago now, but it follows a really simple format explaining like concepts like white fragility and things like that, which are really a helpful place to start to get you thinking. And those anti-racist observatory principles are also really good education. I guess I'd also like to say, start to communicate that messaging to your teams and to your colleagues quite early on. Like, you don't need to have it all sorted in your head before you start to talk to people about it. Just that like drip, drip, drip effect can be really useful. Because it takes us all, like, we need to start to have those conversations and question things. And I suppose by doing that, hopefully over time we'll create psychological safety for people within our teams to speak up about things happening, if we're open to it and we're kind of on this journey ourselves. So how do we do anti-racist planning? So if you have your own data, your own race and ethnicity data, and I know that a lot of boards are improving their collection of it based using some of the equalities data resources, which is really brilliant. And if you don't have your own data, there's lots of good data sources. So there's a report published in 2023 by Public Health Scotland, which looks at all data across health outcomes, and it gives you like a breakdown for different ethnic groups and different health areas. So that can be a really good place to start. There's also there'll be also like work developing over time. Like there's work to link the CHI to the race and ethnicity data to the CHI, and there's also like PHS have developed work on a race and ethnicity reference file, and there'll be, in the future, there'll be reports on different health outcomes based on this like picture of people in Scotland who are racialised. So that's important because like the trends are across Scotland. What you'd need to do is look at who is within your population group, and if you know you have like if you know you have Bangladeshi people living in the community or Black people, then look at what the health inequalities are for those people, and you can it is great if you've got your own data, but use the data across Scotland, because that's the by and large the trends will be similar depending on the different ethnic groups if you compare it to the national data. So once you know your data, you can develop a quality improvement framework, and that will help you to like work through the different types of data that you can analyse. There's a great example of work that's been done by NHS, GGC, and Lothian also have an example within maternity care. So I've linked some of them in these slides, and I really recommend watching those examples and reading the slides. So it's really important to understand your population and who is within it. Different communities, Chinese communities will need different approaches and different will have different outcomes that need to be changed and improved. And think about the inequalities nationally. You don't need to like go into populations directly and ask them about their inequalities. Just like use the data to look at that. But go to people and start to talk to them about what the issues are that they're having. That can be more about experience and like their experience within the service rather than their health data. But also think about psychological safety. So if your staff or community numbers are quite small, people might not want to speak up. And that doesn't mean to say that there's not a problem, but what it means is that, people would be worried that they'd be identifiable. So it's really a good idea to speak to the third sector instead about what some of the issues are within communities for like experience of NHS services, or like, if the people know about different, there'll be absolutely an amazing wealth of knowledge. And if you don't know who your third sector organisations are locally, the third sector interface is a great tool is a great like organisation, or the local CVS would help you to like put you in touch with local third sector organisations. But there's also bigger organisations and lots of different diversity of organisations within the Central Belt, and you could still contact them and try and do engagement with them, because those people are experts and you don't need to go and speak to people like individuals with lived experience themselves. You can go and like draw on the expertise within the third sector, and that is like safer as well, because those people are professionals rather than like individuals themselves that have already experienced that racism. So we need to like acknowledge power, and we need to like really become aware that most services have been developed by white people for, without us realizing, for white people. But we need to bring diverse voices around the table at an early stage. And we need to make sure that people, we're not just speaking to the same organisations all the time or one representative, that we want to make sure there's different communities involved, and the appropriate communities as well for whatever you're trying to change, whatever health outcome you're trying to change. Try not to be focused on what the outcome of services should be. You can still drive your objective while you let people shape what the solution should be, and do it in partnership. So the examples in Lothian, in Grampian, in NHS Highlands, and in NHS GGC, and I know there'll be other brown examples developing right now, but there's four boards there that have done great work with different communities of people to improve services directly or to develop like a better solution for different communities. So there's like really good practice there already, and it'll be hopefully through the peer network there'll be good learning and good sharing. So you really need to have like good, robust accountability and governance to do this work well. You need to have people with anti-racist expertise, and if you don't have that within your board, you need to think about like how you would get that. Maybe you can call upon the third sector if you can. you need to be thinking about like that psychological safety again. You know, it's just it's part of it, and you won't get the right governance if you don't do that.
Sorry, Ailey, just a time check. Just got about a minute left.
Yes. Thank you. Yes,
Thanks.
that's great. I'm just finishing up here. And yeah, and that's my last slide here. But yeah, I guess the you want to put measures in place to measure outcomes nice and early on, so you're not like so you're not thinking about that as an afterthought. And those are some of the topics I suppose that we could also cover in that peer support session. So we haven't now left very much time for questions. But I also see that there's not loads of questions more arising from what we had before I was finishing sharing. And what I was saying in the chat earlier is, so we would hopefully like cover some of the topics that people would like to learn about through the peer support sessions. And you can email me directly if you've got things you would like to learn about directly. We will send out all the presentations and the recording for this session by email, so you can share with your colleagues, and we'd really, really welcome that. You can email us directly, and email Andrea Linson at Scottish Government if you've got specific questions for her. But yeah, we have an open door. We can support with like lots of different questions. So please feel free. I'll put my own email address in the chat as well. I just wanted to close by saying thank you very much to Gwynetta Curry and to Emily McSwiggan for speaking today. I think I really agree with so many of you who've said this is a really powerful session, and lots of really new different evidence and different data than people were previously aware of, and some stuff that will hopefully be really useful within your boards. But thank you all very much for attending today. We had about 73 people and on I think the top count, and that's really, really brilliant. We're really pleased that you all attended, and you will hopefully share the learning with your teams and the presentations when we have it recorded. Yeah, you can send that on to other people. But yeah, thank you very much. And yeah, we will be in touch with different things in the next couple of weeks.